We do need to make sure that our teeth are in an orthopedically stable situation. And you should never trust what you see in the mouth because the teeth may fit beautifully. But if the condyles aren't seated properly in the fossa, then it's like basically having a house built on quicksand. And this is a big thing that I see a lot in orthodontic treatment and others where they're just thinking about, all right, let's fix these, and they're not paying attention to the foundation of the house. The teeth are the window dressing. You are not a carpenter. Even a carpenter diagnoses. You need to diagnose your patient prior to doing anything to them to figure out what really is going on. Medicine, including dentistry, is 7 parts diagnosis, 2 parts treatment planning, and 1 part execution. So if you get all that, those first 9 parts wrong, you're not treating the patient. You may be treating a symptom, putting a Band-Aid on something, but you're not getting the full picture. But we're really storytellers, we're detectives, and we're looking at the imaging to try to find the stories in the history that the patient can't verbalize themselves.
In our day-to-day dentistry, we take bite wings, we take periapicals, and if you're lucky enough to have a Panoramic or a CBCT machine, we may take some of those. But what do we do when we have that TMD patient? TMD obviously being an umbrella term. Listen to a lot of the other episodes on this podcast to learn more about TMD and how we can help as general dentists. But the question we're really going to explore in today's episode with an absolute sensational guest, the author of this book right here for the audio listeners is Temporomandibular Joint and Sleep Disordered Breathing by Dr. Dania Tamimi. And let me tell you guys, you are in for an absolute treat in today's episode. Some of the analogies she uses and the ways to explain certain elements of TMD, like for example, the clicking joint, or the posh way of saying it is disc displacement with reduction. And so many colleagues get confused with that part with reduction. They still have no idea what it means. I've spoken to board certified prosthodontists on the phone, and even they have been confused about what this actually means. And so what Dr. Tamimi does in this episode is gives you one word to substitute in a way that suddenly all of this makes so much more sense. All her analogies are brilliant, and we will explore, does a panoramic radiograph have value? When should we be considering taking a CBCT of the joints instead? And are there any special instructions when doing so? And when do we need to take an MRI scan for the TMJ? And a little bit of a spoiler alert, my experiences with the MRIs have been just crazy in the sense that the person who reports it will make a huge difference to the diagnosis. Let me say that again. If you send your patient for an MRI of the TMJs, well done, you might have helped here. And for the certain patient, we may be getting closer to the truth of the diagnosis. But the report can be so shockingly poor, in my experience, that MRI report ends up being a waste of money. I've seen this a few times now in my short career so far. And we discussed that. I confronted the radiologist, Dr. Tamimi, on why this is happening, and she had a really good answer actually. So get those onions ready, Protrusive. Lots of chopping to do as you listen to these gems. Hello, Protrusive. I'm Jazz Galanti, and welcome back to your favorite dental podcast. This is the first AES Takeover. Every year, the AES put on a show in Chicago around about the 2nd, 3rd week of Feb, and Dr. Tamimi is one of the guests. And so what we're doing basically is we're getting on these absolute superstars in the world of occlusion and comprehensive dentistry to create these awesome and engaging podcasts, but also shine a light on the good work done by the AES. Our guest today, Dr. Dania Tamimi, is one of the speakers. And guess what? Yours truly, me and Mahmood, will also be speaking at the AES 2026 in February. Our topic is occlusion, basics and beyond. Basically, we want to put something together for the younger colleagues and cover the foundations of occlusion that you can apply on Monday morning. But the AES has a reputation of actually being leading and at the cutting edge of comprehensive dentistry. Let me just talk you through the lineup, right? So this is the Protrusive Dental Pearl, by the way. Get yourself to AES 2026. Okay, well, I'm kind of kidding, but I'm kind of not, okay? The real Protrusive Pearl behind this is don't lose touch with the magic of in-person learning and the magic of conferences where you get to meet your peers. Online is great. I've been a fan of online since I graduated, but I also mixed it with in-person events, obviously minus COVID. If all you're doing is going to in-person events, then you're missing out a lot online. And if all you're doing is sat in front of a laptop watching videos and webinars, you're really missing the true essence of dentistry, which is the people around you, the new and old friends that you get to see and the connections you get to make. And this is what me and Mahmood loved a few years ago when we went to AES. We met our heroes in occlusion, and it's an absolute honor to be invited to speak. The theme of the conference is the evolution of the oral physician. It's on Feb 18th and 19th, 2026. So that's Wednesday and Thursday. I'll just name a few of the speakers, okay? We have Mariano Recobado talking about orthopedic stability. If you don't know about Mariano Recobado, he's a big deal in the world of TMD. He's a world-famous physiotherapist from Chile and really a pioneer when it comes to craniofacial therapy and physiotherapy and the temporomandibular joint. We then have Javier Vasquez talking about facial growth, development of functional aging, and the foundations of joints, muscles, airway, and teeth. I mean, it brings together all the systems. There's nothing more comprehensive than that. Then we've got the Jeff Rouse, who'll also be coming on the podcast as part of the AES Takeover. And his title is really interesting. It's Shifting Paradigms from Mechanical to Biological Explanations of Dental Wear. So we see tooth wear on a daily basis, so that is very exciting. We have Tracy Nguyen on proactive dentistry, the cost of watchful waiting. Look, in the UK especially, we like to watch things, okay? We like to monitor and watch things, but at what point are we doing a disservice to our patients? So I really like that, especially with cracks. I've become more proactive with cracks over the years. Not so much invasive or aggressive, just more proactive. The next speaker is our guest today, Dr. Dania Tamimi, and her title is so fitting with the podcast today, right? Her title for AES is Telling the Story of Your Patient Through Imaging. And you'll definitely catch glimpses of that from today's episode. We then have a very clever chap called Jay Levy. I sat next to him at lunch at AES, and honestly, one of the most intelligent people I've ever met. The title of his lecture is The Biotensegrity of Occlusion. Look, I don't know if I should be admitting this or not, right? But I have no idea what biotensegrity means. Maybe this is embarrassing that I don't know, but you know what? I can't wait to find out. Biotensegrity, here we come. And lastly, we have Jeff Sausenstein, who's a former pro tennis player, and he's talking about mind matters, prioritizing mental and physical health for the oral physician. And so what the AES like to do year by year is have a non-dental topic, but something that's made relevant to us as dentists. So I just want to walk through day one. In the next episode, I'll walk you through day two. But if this sounds interesting to you, and it should be, because you listen to Protrusive Dental Podcast, you're probably interested in these topics, head over to aes-tmj.org and have a think about joining us in Chicago. If enough of you tell me you're coming, we'll arrange some sort of like a protrusive get-together. So me and Mahmoud are so excited, but let's get to this main episode now with Dr. Tamimi, and I'll catch you in the outro. Dr. Dania Tamimi, welcome to the Protrusive Dental Podcast. So nice to have you here. I've heard so much about you. I'm excited to see you next month, fingers crossed, all being well. And you are a podcast veteran. So welcome to our podcast now. How are you?
I'm very well, thank you. I'm very happy to be here and happy to be talking to you as well.
For those who haven't heard of you yet, tell us about your career so far. Tell us about your journey. Tell us about what gets you excited.
Oh gosh. About me, I mean, other than mom of three and all that stuff, that's because that's central in my life. I am an oral and maxillofacial radiologist. I'm a dentist, just like you guys, and I'm trained in oral and maxillofacial radiology. I'm board certified by the American Board of Oral and Maxillofacial Radiology. And I've spent almost 2 decades now trying to figure out this TMJ thing. And I've been very lucky to have some really amazing teachers like Dr. David Hatcher and Dr. Rod Avenshine, who's an anatomist, all dentists. And these people and many others have basically shaped the way I think, shaped the way I see imaging. And, as radiologists, you tend to think of us as the people who are trying to find pathology, get you out of trouble. But we're really storytellers, we're detectives, and we're looking at the imaging to try to find the stories and the history that the patient can't verbalize themselves. Okay, so what gets me excited, many things do get me excited, but when it comes to this stuff, this radiology stuff, what gets me excited and what gets me excited to teach imaging interpretation is the light in people's eyes when they realize it's more than just a static image. It's a chronicle of someone's life. And through the patterns of bone trabeculation, through the morphology of someone's face, you can see those patterns manifest, the patterns of movement, the patterns of function, the patterns of growth. And that tells you a lot about your patient that they cannot tell you in their words, So that gets me excited. And I guess we're here to talk about TMJ, so I'm very happy.
Amazing. Well, I love that storyteller reference, and allowing the patient to verbalize it through the medium that's presented, and being a storyteller. That I've never heard that I'm never going to forget that. That is wonderful. I mean, I have so many questions today to ask, and just so I know, I would have mentioned this in the intro, but this is part of the AES Takeover. We're planned to be speaking in February 2026. One of the biggest stages when it comes to TMJ and occlusion. So very, very excited to build up excitement for that event. At the end, I'll ask you again to describe what you're talking about at that event, as well as where else we can learn from you. But the place I want to start with in this exploration of TMJ imaging with you is starting with, I guess, radiographs that dentists are most familiar with, which is 2D. And let's go with OPGs, right? OPGs, call them what you want. So my first question to you, Dania, is there enough diagnostic value in OPGs? To give you some context, in the UK, obviously we have an international audience, but in the UK, they will not accept a referral to the OMFS department without an OPG. Even if my diagnosis is purely muscular, right? And I have a fantastic mouth opening, and I know that clinically there is no evidence of disc displacement, all these things, they will still reject your referral unless you have an OPG. What do you think?
That's kind of interesting. I've never heard that one before. Here in the States, the surgeons will just take anyone, without, well, I mean, of course, with a referral.
This is the public route. This is the public route,
right.
public funded route. Yeah.
So
yeah.
I got it. Okay. I guess they want you to do your due diligence and make sure you rule out anything osseous. But I mean, when it comes to TMJ, that's kind of short-sighted. And for a community that kind of cares about, like, makes a big hoopla about cone beam CT and radiation, that's kind of interesting to hear,
Isn't it just?
It is. And, a big portion of TMJ disorders, many of these TMJ disorders are muscular. They're extracapsular. There are things that reside outside of the area of the TMJ. Yes, you can have referred pain from other places, like you can have referred pain from the sinuses, from the teeth, from the neck and whatnot. But in the end, the diagnosis is more of a clinical diagnosis. And, that kind of makes me a little upset that they would expose someone to radiation for no reason, just to tick a box, to satisfy that requirement. Right,
I was unsure how you were going to respond to that. I'll be honest with you, because as a radiologist, right, I would have thought that you would have a bias towards, yes, imaging, more images the better. So I was a little bit, and I'm happy for guests to disagree with me, but I'm so glad that you were also as feeling the same way that I was when these referrals get rejected. Now, most dentists will, tick the box and get the OPG and send it to them and get that referral done. I feel very uneasy about that. But then let's twist it a little bit. When the dentist, who most dentists, unfortunately, I don't know what it's like in the States, but when a patient comes with a temporomandibular joint complaint, dentists often get a little bit nervous. Like, for example, dentists will tell me, hey, Jazz, I had a patient who had TMJ, they'll call it TMJ. Patient had TMJ, and they had canine guidance on the left and group function on the right. That's kind of descriptor I'll get from the dentist. And then the next thing, like, I'll take an OPG, right? And so where does that come in terms of the decision making, and when is it appropriate?
Gosh, you have to really, this is multifaceted. You really have to think about this, First and foremost, okay, so I'm a radiologist. So I am, as you said, you thought correctly, I am biased towards imaging because that's my job, right? But I have enough knowledge about imaging indications, contraindications, pros and cons and things like that. And in addition to a healthy respect for radiation, But I also have a healthy respect for getting the right diagnosis, because if you don't get the right diagnosis, then you're not treating your patient. It just boils down to that. You need to have the correct diagnosis in order to come up with the correct treatment plan and execution of that treatment plan. Medicine, including dentistry, is 7 parts diagnosis, 2 parts treatment planning, and 1 part execution. So if you get all that, those first 9 parts wrong, you're not treating the patient. You may be treating a symptom, putting a Band-Aid on something, but you're not getting the full picture, okay? And you're not treating that person, okay? And unfortunately, as you know, in healthcare, and I'm sure it's the same where you are, things are pretty disjointed, no pun intended. They're just, people tend to specialize and subspecialize and have extra specialization and interest in certain things that they get tunnel visioned. And you get to just see that thing that you're interested in, and everything else blurs out. And that is a big problem. And when I teach people to read radiographic imaging, regardless of what that is, I tell them, here's what you need to do. First thing is lose the tunnel vision. Okay. And what that is, and that comes from our biases. We're trained as dentists. We like teeth. If I liked shoes, I would look at shoes. If I liked handbags, I would look at handbags. When you meet someone with class 3 caries, you can't help but think of a spoon excavator going into that soft caries, right? Or round burr or whatever. You're doing the procedure in your head. You can't help yourself. If you're an orthodontist, you're classifying people, right? Class 1, class 2, class 3. So what it boils down to radiographic imaging and the choice of what image needs to be obtained, it boils down to the diagnosis, okay? So a clinical diagnosis. And let's talk about an ideal world where insurance and NHS and all these things don't exist, okay? You diagnose the patient. You have to see your patient first. And I know that this doesn't fall into many assembly line clinic forms that we have in the world right now where tick, 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 get to the next patient, But the right thing to do is to diagnose your patient clinically first, figure out what they have clinically, and then choose the appropriate imaging for it. It may be no imaging. If it's a muscular temporomandibular joint disorder, it's going to require no imaging. If it's, for example, trigeminal neuralgia, you're not going to be doing a Pano for that. Right, it's going to require an MRI because that's a soft tissue kind of thing. You need to figure out what's going on in terms of like the trigeminal nerve and all the vessels that surround it, if any. Right, and if you decide it's a sinus issue, then that's going to be another set of radiographic imaging. It's different for every single indication, every single diagnosis. Okay. And I also understand that not everybody has access to the toolbox. We have a big toolbox in imaging in dentistry. We have, our plain films, we've got our cone beam CT, we've got MRI, some people have ultrasound as well. Not everybody has access to all that. So sometimes we just have to make do with what we have. But if we do have access to the toolbox, then we have to think about what is the best thing for this patient. Now, when it comes to TMJ, if you decide that it's an intracapsular disorder, then you have to think, is it a hard tissue or a soft tissue kind of situation? Because if it's soft tissue, MRI is the way to go. And if it's hard tissue, and you determine that through clinical examination and also viewing what's happening in the face, the bite changes, the mandibular symmetry, the growth of the mandible, that sort of thing, then you're going to need hard tissue imaging. 3-dimensional hard tissue imaging and cone beam CT would be the way to go. Right.
Can you explain more about the soft tissue for our younger colleagues who may not be familiar or remember the anatomy class they had some years ago about TMJ?
Oh gosh, the intracapsular soft tissue, right?
That's right.
Oh, this is going to be hard for the audio people to listen to, but I'm going to try to describe it as much as I can. Okay, so you've got a condyle. I'm going to just hold my hand up here if you guys want to watch, those audio people want to watch this later. My hand, that's the condyle right there. Okay. And then you've got the fossa, right? So you've got two rounded surfaces against each other, and the place where the height of maximum curvature of those two rounded surfaces is an area of constriction. And that's where the thinnest part of a bow tie, which is what the disc looks like, sits, right? So the disc looks like a disc, like if you take it out of a cadaver or even like another person, a normal disc looks like a disc. It's an oval and it's circumferentially thickened. But when we cut this in a cadaver or cut it in MRI, you've got a posterior band, which is thick, and then you've got an anterior band, which is thick, and then you've got the intermediate zone, which is thin. Think of a red blood cell, okay? Take that red blood cell and cut it in half. That's what it's going to look like on MRI, okay, in that sagittal cut. Now, in order for the joint to function properly, all the components need to be sitting in the right place, okay? So this is a very high-loading joint, right? Your condyle is an osseous surface. The fossa and the eminence are also osseous surfaces. What sits in between those two and what cushions these two is that disc, that red blood cell, right? Shaped thing, the bow tie, right? Okay, so now this disc has the ability to dissipate a lot of the loading. It has the ability to get rid of the majority of the loading if the person is functioning properly. But it's a material, and all of us have studied material science in dental school, and everything in the world around you is a material, right? And your disc is a material, and your bones are materials. And every single one of those components have limits, have thresholds. Okay. So if you surpass the threshold that this disc can function at, then it starts to break down. It's made out of collagen. There's a lot of collagen, there's water as well. And if you just load it too much, it will break down and it'll change shape and it's no longer going to fit nicely in that configuration that I talked about. Think of a jigsaw puzzle, all right? The disc sitting in between those rounded surfaces like a jigsaw puzzle, fitting perfectly. And then just imagine your dog chewing up that disc, part of the jigsaw puzzle, all right? Try to fit it back in, you won't be able to, all right? And so that disc doesn't fit in that area and it's all mangled and it cannot stay in the place where it can protect those osseous components. So that is the internal derangement and disc displacement. Okay, so disc displacement, you guys have probably heard of reduction and without reduction, and that is just confusing like heck. The terms reduction make people I think go cross-eyed. All right, so reduction can be very confusing for people, especially, in our minds, if we're not medical, when we first start as dental students, whatever, we are, we have an idea of what reduction is in the real world, which is basically the subtraction of something, making less of something, or, something that you make in the kitchen with red wine, poured out over some meat, that kind of thing. Yeah, and so it's hard for you to conceptualize what reduction means for the TMJ, and unfortunately in our dental school programs, they don't do a very good job of explaining it to us. Okay, what is this reduction thing? So I'm going to just give you a word to replace reduction with, and then everything's going to be clear. Recapture. Okay, recapture. So when you have a disc displacement with recapture, as the condyle rotates forward and slides forward, it will snap back onto the disc and the two will move forward together. And as the condyle goes back into the fossa, the disc slips off again. Okay, so that is with recapture or with reduction. Okay.
I love it.
All right. And then that can progress as more morphologic changes happen to both the condyle and the fossa and the disc. There will be no recapture. Okay, so as the condyle moves forward, it doesn't recapture the disc, and there is disc displacement without reduction or without recapture. Okay, in the beginning of that, when that first part of this displacement without reduction occurs, there is a closed lock. There's a mechanical inability to open the mouth. Okay, but with time, the TMJ, which by the way stands for the miracle joints, will fix itself, will regain range of motion. Okay, so you may have noticed a little click when there was recapture. Okay, that's the clinical symptom for that. And then when there's no recapture, there's no click. Mm-hmm. Your patient may be already at that end stage disc displacement without recapture and have full range of motion and no clicking and popping, but they have a compromised disc, a compromised TMJ, because that disc is supposed to be the cushion for the bones. Now, what happens to the bones? After not being cushioned for a while, they're going to start to change shape and they're going to start to remodel and flatten out. Instead of being two rounded surfaces against each other, they rub against each other. It's called eburnation, where bone starts to flatten out. As two bones rub against each other, they become parallel to one another. And then the bone is also a material, and when the bone can't take it anymore, it's going to break down. And that's going to look like erosions, low density areas in the articular surface of the condyle and also the fossa, which will eventually heal itself and remodel, okay, and repair itself. The miracle joint will repair itself to bring you back to function, okay? Now, there are consequences to this. There are consequences to the destruction of the condyle, which, by the way, is a very important factor in the growth of your face. Mm-hmm. And if your TMJ is compromised before your face stops growing, then you have facial growth problems. You have asymmetries, or you have retrognathia. A lot of your class 2 patients are not class 2 because that's the way they were conceived, or not conceived, but that's the way that they were, their genetic makeup, It's a consequence of a younger version of degenerative joint disease called idiopathic condylar resorption, which I don't like the term, but that's what they call it. Okay. Now, what is all this? This whole thing is a continuum. right? The soft tissue destruction, followed by the hard tissue destruction, followed by the repair. In the end, the miracle joint will repair itself so that you can come back to function, because you need to do a lot of things with your mouth. You need to eat, you need to drink, you need to breathe if your nose gets clogged up, you need to speak and communicate. And if your joints don't work properly, you won't be able to do any of that, right? So I believe in God, and I believe that He created this so that in a way that we can still regain function and still maintain our lives after the destruction of our TMJs. Unlike any of the other joints that need to be replaced, when they've gone whack, the TMJ rarely needs to be replaced after degenerative joint disease. So I think we need to circle back to imaging, right? Because like you were asking, yeah. So I
just wanted to just clarify the importance of what you said there for our colleagues listening, because I still meet so many dentists who believe that when the click happens, that's the disc moving out of position. That's the wrong thinking. It's quite the opposite. Like you said, you summarize it beautifully with that word recapture, and substituting that word reduction to recapture has helped hundreds of dentists finally get it. Because you're right, reduction is a very confusing term. So that's a real pearl right there.
Right. So now what imaging do I use? Okay.
Essentially, the crux we're going then is, okay, so where do OPGs come in? Where do cone beams come in? Where do MRIs come in? I know we talked about countries having difficulties in access, but in an ideal world, through you, through your eyes and through your mind, we can develop some indications and ideals.
Right. Absolutely. So if you're looking, like I said before, if you're looking for soft tissue changes like this disc displacement with reduction, without reduction, some other intercapsular changes that I won't have time to really talk about much today, those need to be looked at with MRI. Okay. An MRI is not a negative CT. It's not a negative cone beam CT. There's a technology behind it that helps us visualize fluid and fat, which is a big component of what we're looking at here when it comes to the anatomy that we have. Okay, especially in the world of the TMJ. So, yeah, I don't want to get too much into MRI technology unless you want me to, No,
I think we can go over the broader indications, and that's better, I think.
The point that I'm trying to make throughout all this is that with the destruction of the TMJs, there are going to be downstream effects. There are going to be downstream changes to the face. There are going to be downstream changes to the occlusion. There are going to be downstream effects to the airway, because of the nature of the connectedness of your occlusion and the TMJs. You don't just have two joints at the TMJs. You've got all these other joints, which are not synovial, which are the teeth. As they come together, you've got hard surfaces coming together and functioning against each other, and they are related to your TMJs. Okay, so if your condyles are reduced in size, then with that reduction of size, that creates a space in your joint space. Just imagine, if you were to take a condyle, whatever it is, that condyle is chopped off from the top, So the space that condyle inhabited is now going to be wiggle room. Okay, and it's not chopped off, but the destruction that I just described here with the erosion, the active destruction of the bone, secondary to biomechanical extra loading and inflammation and all that, that creates wiggle room. And this wiggle room is orthopedic instability. Okay, so your joints need to be orthopedically stable. And if the condyle is out of the fossa, then there's a high likelihood of that condyle sitting back into the fossa and changing the occlusion. If it happens on both sides and both condyles move upwards, then the bite opens up in front. If it happens on one side, then you can have a contralateral open bite on the other side, and you can have occlusal cants and all kinds of things occur. So tying it back to dentistry, we do need to make sure that our teeth are in an orthopedically stable situation. And you should never trust what you see in the mouth, because the teeth may fit beautifully. But if the condyles aren't seated properly in the fossa, then it's like basically having a house built on quicksand. And this is a big thing that I see a lot in orthodontic treatment and others, where they're just thinking about, all right, let's fix these, and they're not paying attention to the foundation of the house. The teeth are the window dressing.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Right? And you don't put the window dressing up before you build the foundation and the walls and all that. And the foundation and the walls would be the TMJs in the airway. Okay.
I love that you described the teeth as joints. That was really nice. And it reminds me, everything you said there really reminds me of something that Jim McKee said on this podcast before. Think not how the occlusion affects the joints, think how the joints affect the occlusion. And I think when people really understand that, that's the next higher level thinking of occlusion beyond the teeth.
Mm-hmm. So now let's tie that into the imaging. Okay. When you acquire a panoramic image, which you guys call an OPT or an OPG, right? What do you do with the teeth? How is that acquired?
Use your cotton roll or the little plastic.
Right. You use a bite stick. So what happens
Mm-hmm.
with the TMJs if you come into protrusive?
It's translated or potentially translated, right?
They're going to move forward, right? So you're not going to capture the joint space. You're not going to capture the relationship between the condyle and the fossa. You won't be, that's a very integral part of your diagnosis. And yes, there are clinical ways to evaluate for orthopedic instability, but you know, when you have the entire craniofacial complex in one view, like you do on cone beam CT with the teeth together, which you can't get with a Pano because you need to have the mandible in protrusive in order to capture the jaws in that focal trough. If you go back to your Pano textbooks, whatever, you know, you'll understand that that's how Panos are acquired. You know, there's a focal trough and everything outside it is blurred. And if the things aren't in the focal trough, then they're going to be blurred. And that's why we bring the mandible into protrusive, to make sure that we can see all the teeth and, you know, in the jaw, because the lower jaw is usually a little bit inset, you know, so we bring it forward in order to bring everything into the same focal trough. So another thing that the panoramic image isn't really great at, other than, you know, looking at that orthopedic stability, the position of the condyle in the fossa, is the actual morphology of the condyle. Okay, so when you think of the condyle, you know, it looks like a kind of like a spatula if you look at it head on, right? It's rounded on the top. And like if you look at it anterior posteriorly, it's rounded on the top, you know, and then it's got a thin neck. So it kind of tapers in that way. Now, if you turn that spatula to the side, usually a spatula has a little rim to it. Okay. Now that spatula isn't aligned completely mediolaterally on a pano because of the nature of the projection geometry here, because of the way the pano is created. What tends to happen is the lateral pole moves down and forward. So this is what you're looking at. If for those who are in the audio, if you want to come back to the video, this is what you're looking at. You're looking at a distorted view of the condyle on your panos, not the true mediolateral dimension like you can with the cross sections that you get on cone beam CT. And also, you're not going to be able to pick up the erosions that are indications of early active degenerative joint disease or inflammatory arthritis, you know. And that diagnosis is super important before you start working, because you don't want to be working on someone who has active degenerative joint disease, because through the changing of your biomechanics, the biomechanics of the patient, you can actually create more of a problem. You can create a greater magnitude of destruction in that area of the condyles. Okay, so the inflammation, it's inflamed. You know, you're not going to pour fuel on the fire. You know, you just want to let it be. You don't want to start moving teeth or doing orthodontic surgery or anything like that if somebody has an active disease process, active degenerative joint disease process. And these erosions, when they're small, you really can't see them on cone beam CT. And in fact, many times you can't even see the big ones because of all that projection geometry distortion, you know. Anyway, so Pano, okay, if that's all that you have, that's all that you have, you know. But then the ideal way to image for osseous change, in my opinion, is using cone beam CT. And I'm not going to just say, okay, just get a cone beam CT of the TMJs, like one small one on the right, one small one on the left, because then you're just getting the anatomy, all right? This is the functional joint, and the place of interest for you as a dentist is the teeth. And you need to know how these two are related. Okay, are the teeth in maximum intercuspation during the acquisition of the cone beam CT? That's a very important thing to know prior to interpreting the joint space of your condyles, you know, when you're looking at their imaging. All right, so the teeth in maximum intercuspation is important, and also acquiring a field of view that it encompasses, I mean, in my opinion, everything from glabella down to hyoid, so that you're viewing this craniofacial complex as a whole. There are downstream effects of temporomandibular joint disorders to the mandible, but also to the growth of the face, you know, the growth of the airway and position of the neck, how much space you have here. And I know not too many people are on the airway, you know, bandwagon, but, you know, what's the most
Well, the
important
people
thing that you do
listening
with
to
your
this will
face?
be, especially those who, you know, come into AES and subscribe to this, that, you know, we're speaking
Right.
to the converted in a way.
What's the most important thing that you're going to do with your face?
Breathe.
Breathe. Try not breathing for 2 minutes, right? You know, you cannot eat or drink for whatever. There's an alternative, you know, IV, whatever, for nourishment. But breathing, that's it, you know. Well, unless you do like a tracheostomy or something, and who wants to do that, right? But the way that your face forms is very highly related to the function of your TMJ and your jaws, okay? So you need to look at all of that together and determine the patterns of change, the story in the patient's scan, by looking at the whole thing together. And part of my frustration when I get scans from Europe, you know, is those small fields of view, one here and one here. I'm like, okay, I'll tell you what the condyle looks like and where it is, but I can't tell you if it means anything to you. And I can't tell you if it's doing anything anywhere else, you know. And sometimes even a condylar hypoplasia can be very subtle. And the only way you can tell it's a condylar hypoplasia is what it does to the rest of the mandible, because the mandible is going to follow the TMJ, and if the condyle doesn't grow to full potential, the mandible doesn't grow to full potential either. Yeah. Anyway.
So if you have a patient then who you suspect it is either degenerative joint disease or it is osseous issue, and you're requesting, you've laid out your guideline that you'd like cone beam, which shows more than just small views. You want it encompassing so much more. With that, and you want it in MIP or their teeth together, or at least the description of what position it is in, but then is that enough, or do you need another one with the mouth open as well?
I don't think that you would need an open cone beam CT. You can tell where the condyle is just by palpating. All right. And that's basically the information that the the cone beam CT will give you. It'll just tell you where the bones are in relationship to one another. If you're looking for things like, intercapsular changes, the disc, whatever, that's an MRI kind of thing. And that's where you would get an open and closed. But I don't think that an open is indicated. Now, some people will argue with me, and I'm going to say, okay, if you really want to do that, then get a small field of view, because you don't need to get a large field of view in the open view. You already have the anatomic information from the closed view. In order to limit the imaging radiation to the patient, you can get a small one here and a small one there for that open view. But once again, I don't think it's important. Okay. There is, someone once challenged me and said, okay, what about with coronoid hyperplasia? Coronoid hyperplasia where the coronoids are really large and we want to see what they do with opening. Sure. But you can tell that there's a coronoid hyperplasia. You can tell how big it is, in relationship to the level of the condyle and whatnot. So, what more is it going to tell you? What is the imaging going to tell you? That's a question you always need to ask yourself. Can I get the diagnosis without imaging? Okay. What is my question? What is the question that I want to answer? And if I can't answer the question clinically, then I have to find another way to answer it. Let me choose amongst my toolbox something that may have less radiation. So for example, I'm not going to send the patient for a medical CT because that's a lot more radiation. But if that's the only thing that I have and it's really indicated and I can't get the information any other way, and that's the way it is. Just yesterday, I was working with someone who has their patient goes through the VA system, Veterans Affairs system here in the US. And the only way that they could get that reimbursed was to get a medical CT. And of course, I'm like this, but it is what it is.
I appreciate that. I think that's a very honest, real-world view of that. You have to work with what you have. So far we've covered cone beam CT, and you gave us the guidelines in terms of don't take it too small. We know we're looking for osseous changes. We talked about soft tissue changes, intracapsular. We're going to go MRI. Are there any situations where an OPG has value, therefore? Like in a perfect world, if you have access to all this, are we suggesting that we don't need an OPG ever? Or I never say never, obviously, but that is a inferior choice, and you as a radiologist, once it gets to a point where the clinician's unsure of a diagnosis and they need the imaging to help their clinical, that perhaps that doesn't have as much value.
It's a case-by-case kind of situation. Okay, it's a case-by-case kind of situation. And, I just have to say that, if you get a Pano for let's say, for example, an implant case, you know that you're going to put a three-dimensional object in a three-dimensional object that has anatomy that you have to avoid. So why do you get the Pano to start with, right? Okay, it's just using your mind, just use your brain, think about what you're going to do in the long run, okay? Let's say it's a surgeon who has wants to remove impacted third molars or partially impacted third molars and wants to see where the canal is, Depending on where the level of the tooth is. If the tooth is slightly apparent in the oral cavity, maybe it's far away from the canal and they don't have to really worry about it, Let's say that the teeth are fully erupted or partially erupted, but if the tooth is submerged, then most likely it's going to be close to the canal. And then the question is, where is the canal in relationship to the tooth? Because the canal can be going through the roots. It can be behind, like lingual or buccal or inferior, whatever, So it's the level also of the confidence of that surgeon that would maybe want to do this with a Pano, not get a cone beam CT. And as we know, insurance also dictates this, They're not going to pay for a cone beam CT. They will pay for a Pano, and that's what they have to, what the clinicians have to contend with, My point is that if you clinically believe that a cone beam CT is indicated, you should not hesitate to get that as your first imaging. Okay, don't get the Pano to just see what's going on and then get the cone beam CT. Clinically, if you make the decision that the procedure that you're going to do is going to require a three-dimensional evaluation, you're going to be moving things in 3 dimensions, you're going to be removing things that may be impacted, right, in contact, compromising other structures, don't fudge with the 2D, My opinion may not be popular, but I just, as an expert witness in many malpractice cases, I'm just going to tell you that the first thing that the lawyers do when things go wrong is put the patient in a cone beam CT to see if that whatever it is that was done wrong could have been avoided by getting 3-dimensional imaging versus 2D. I hate to bring lawyers into this, but you know that I know that's not like forefront in many people's minds.
No, it's true, because we need to bear that in mind when we're making decisions, and also get the right information to do justice for our diagnosis. But in terms of just quickly about a CBCT, are the units that dentists have in their practice that are suitable for implants usually suitable to get that level of imaging that you desire from condyle all the way down? Are the units that we have, are they adequate nowadays?
Well, there are different types of units. You know, when you choose a unit for your practice, you have to look at your practice space. If you're an endodontist, you're not going to need a large field of view. You know, you're going to buy yourself a small field of view to just look at the area of the couple of teeth that you're going to be treating, right? And in the case of someone where you think that the pain is coming from elsewhere, then you can send them to an orofacial pain specialist, an oral surgeon who may require a larger field of view. Okay, so that's in case of the endodontist. In case of the implant dentist, okay, so your periodontist, oral surgeon, implant versus people with affinity to implants. Let's put it that way, because I don't think it's a specialty yet.
Correct,
you know, but
correct.
you know, okay, implantologists. Think about that, what that implant is. You are replacing a functional unit in a functioning being, in an organism. And that functional unit needs to work with all the other teeth and needs to also work with the TMJs. Okay. So you need to see what's going on with the TMJs, because, like, why would you do an all-on-4, for example, in a patient who has orthopedic instability, right? You need to figure out if the condyles are seated properly or not. You know, or if you're going to do even a bridge, you know, you don't want to, you know, an implant supported bridge, 3-unit, whatever it is that you want to do, you need to make sure that the occlusion is sound before putting these pegs that can't be removed or not be removed, but they can't be moved orthodontically. You know, they can be removed with a great deal of bone removal before you make that decision. And I'm just going to give you an example here of a tunnel vision situation. It's an expert witness case that I was involved in. So I'll give you the story from the end, okay? The patient shows up in the emergency room. This is the end, and I'm going to tell you the backstory, okay? The patient shows up in the emergency room. He's got an all-on-4 supported denture. The surgeon in the emergency room doesn't have the screw to remove the denture. The emergency was the patient had bit his tongue, and it swole up, and he couldn't breathe, okay? So the surgeon decided, if I can't remove this, then I'm going to cut everything out. And he removed the alveolar processes with the teeth. He was like working in an emergency kind of situation. Of course, me as an expert witness, I told them he could have done a tracheostomy, but, you know, whatever. Okay. But what's the backstory of this patient who bit his tongue? This patient was partially dentulous for a long time. He had front teeth. He didn't have back teeth. And as you know, your tongue spreads when it doesn't have support, right? It goes just like your feet when you're in flip-flops all the time, you know, like here in Florida. Okay. And so he had a big beefy tongue. And then the general dentist decided that, you know, talked him into an all-on-4. He extracted all the front teeth, or, you know, pterygoid, whatever it is, you know. So implant supported full dentures, okay? And he didn't put into consideration that his arches were narrow. He put the implants wherever the bone was. So by the time he put the implants and then the dentures, he'd crammed that tongue into a teeny tiny space. So of course the patient bit his tongue and it got infected, and then the rest of the story. But that first dentist wasn't on the stand. It was the surgeon, obviously. But if you ask me, you know, the fault came with poor diagnosis, just thinking tunnel vision, thinking of putting teeth in a person without looking at the whole situation, you know? So going back to your question, you need to look at these people more fully. You know, you're not just putting implants in. You are replacing functioning teeth, and those functioning teeth need to follow the system. And you need to look at the integrity and the health of the system, okay? Airway included, TMJ included, prior to putting these immovable pegs into people's mouths and then, you know, them having to deal with the consequences of that. Yeah, so your question was, so are the TMJs visualized there? They should be. I mean, you shouldn't be just getting one arch. You need to be seeing what that, you know, you need to do a digital wax up. You know, if not a conventional wax up, you need to do a virtual wax up. You need to see how the teeth fit with one another. And you need to see how they fit with TMJs. So I don't really advocate those single arch imaging for implants because it's not about where the bone is. It's about how it all fits together. Okay.
And so implant dentists would, when they're dealing with patients, often older patients who've been through a lot more wear and tear, to check for orthopedic stability of the condyles is another important factor in their overall occlusal stability and their planning. Would you agree with that?
Yeah, yeah. You have to look at everything, you know. Implant placement has been oversimplified for, I believe for material gain in many places, the vendors want more dentists putting in implants, the patients want implants, the dentists want to make more money putting in implants. But it boils down to the importance of diagnosis. You are not just doing a mechanical procedure. You are not a carpenter. Even a carpenter diagnoses, You need to diagnose your patient prior to doing anything to them to figure out what really is going on. In the example of patients who, let's say even a class 1, class 2 restoration, a patient has a second molar class 2 restoration that he keeps breaking. And then you do an amalgam buildup and that doesn't work out. And then you put a crown and then he splits the tooth. What's going on here? It's not that tooth. There's something mechanically wrong and you've got to figure that out. Right?
You've got to think big picture. Yeah. With the CBCT, I want to ask you about timing. This is a really important question. And I'm happy to tell you at the level I'm practicing at, and I'm always happy for my guests to scrutinize me, criticize me in any way. I'm always happy to learn, but I'm just going to tell you what I do and my philosophy on imaging, with my experience so far. When I have a good history and a thorough clinical examination, and I have arrived at my differential diagnosis or a diagnosis that, I'm fairly happy with this diagnosis, and I don't think I need imaging with that level of confidence I have for my diagnosis of the various different diagnoses, with TMD being an umbrella term. And if I have diagnosed let's say a unilateral disc displacement without reduction or without recapture, okay, without limited opening, so this patient can open normally. The role of imaging then, in terms of, so some of the previous guests, to give you some more context, Dania, some of the previous guests I've had on, one has been a maxillofacial surgeon who's not that keen on imaging at the forefront, because he says, if I can make my diagnosis and I'm choosing that I don't think we need to do surgery here, then I don't need the imaging because I've got a good diagnosis. Whereas I've had someone else on the show and they're like, every patient needs an MRI. Not every patient, but if you suspect any sort of disc derangement, equals MRI. And so there's a spectrum, all right? And so where would you lie in the spectrum in terms of relying on your clinical diagnosis? And then if the imaging is not really going to add much or change much, when does it come in? So the bottom line is, when do I do it? If something's not going right, if I'm like, I'm doubting myself, hang on a minute, is my diagnosis correct? Or I am not sure of my diagnosis from the outset, that's when I reserve imaging. What do you think?
Well, exactly what you just said. And I think I kind of alluded to it in the beginning. What's the question that you want to answer? And what are you going to do with the answer? You see? Because just like this oral surgeon said, if I'm not going to do surgery, if I'm pretty sure with my diagnosis and I don't see changes occurring, and I can treat this without using imaging, I will, right? I can. But people tend to be lazy, tend to get lazy, say, okay, I need this whole spectrum of stuff because I need to make sure that everything is okay. And you know what? It would be wonderful if we could do that. It would be wonderful if there wasn't a radiation, tax to pay, and there wasn't an actual monetary tax to pay as well, because many of us, we rely on insurance to pay our things, and they can deny it, and then it can get very expensive, especially here in the US, it's very expensive. Okay. So it really is a case by case kind of situation. And what I would recommend to everybody listening, you included, is you just have to hone in on your diagnostic skills, and broaden your mind and broaden your knowledge base, because, even with a clinical diagnosis, your eyes will only see what your mind knows. Okay. And if you're indoctrinated, like with a certain philosophy, and you're only doing it that way, and you're not looking at it in the big picture kind of thing, you're only going to see it through that lens. And that's not how human beings work. Everybody is different. Everybody has a different story to tell through their bodies, through the patterns of movement, through their patterns of function, through their whatever's going on in their head, psychologically, whatever. As we know, there's a lot of psycho stuff going on with TMJ too, right? Okay. The psychosocial component to that. So we really do have to take a step back, and diagnose our patients and learn more about how to diagnose our patients differently from other practitioners and step away from our ego. Okay? Stepping away from the ego, I think, is the single most important thing a healthcare professional can do. Because then if you believe that there's another way to do things, your mind starts to grow. Your mind starts to open up. Okay, so with that arsenal in mind, and if you can't diagnose the patient properly, you have to step away from the ego and give the patient to somebody else. Okay, and then decide, if imaging is indicated or it's not. Once again, it's about the question that you need to answer, and what are you going to do with the answer? Okay, I mean, you can do an MRI for every single person that walks in through the door, and you're going to find a big portion of them have clicking joints, have disc displacement with reduction or without reduction. So, but what are you going to do with the information? Hey, yeah, it's a nice little thing to add to their clinical diagnosis. Yeah, but what are you going to do with this diagnosis? So that's the question. Yeah.
Okay, that was beautifully answered. That's fantastic. Now, to give you a perspective of a radiologist that I'm very fond of in the UK, his MRI reports have been the best. And so this is a two-pronged question. First is that whilst I really respect this radiologist, he has this strong opinion that I want to just ask your opinion. All it is an opinion, but I'd love your opinion on this. He is of a camp that believes that any patient before orthodontics should have an MRI of their joints to confirm orthopedic stability prior to starting orthodontics. Okay, and so this is his belief. Where do you lie in that?
Yeah, there are many people who think different things. First of all, orthopedic stability is a clinical diagnosis. Okay, it can be verified or detected even with imaging. Okay, but the orthopedic stability, the wiggle room, is really a clinical diagnosis. And there are different people who do it differently, different people who will determine that differently, whether you're from the Dawson camp or from the, OBI or, FACE group or whatever, Roth Williams, whatever it is. There are different ways to do this. Okay. It's a clinical diagnosis that can be supplemented with radiographic imaging. And in an ideal world, wouldn't it be nice to have MRIs of every single person that comes through your door? But, we know in reality that's not the case, and it's going to be very hard to convince insurance or NHS to pay for it because there is no standard of care when it comes to that, right? Okay. I'd like to satisfy my curiosity and know where the disc is in every single person, but is that practical? I don't think it is, simply because there are too many things that come into the obtaining of an MRI, or obtaining of any kind of imaging, and too much politics. So
I appreciate that real world view. I don't think it's always practical, but I think what I took away from that is there is a time that we need to do our full history, full clinical examination. And then if we have a doubt prior to commencing something which is essentially full mouth rehabilitation in enamel, orthodontics, or someone's doing implant related work, to then escalate to imaging is a very good thing. Then therefore you can be a bit more, a bit stronger in your recommendation. Whereas if you just did a blanket thing of, if you're having ortho, if you're having implants, which is a big deal, if you're having a full mouth rehab, we better check your joints. Then I think to do a full clinical diagnosis first, to see whether the role of imaging is strengthened and to make it practical for your patient.
More importantly than the orthopedic stability that can be detected clinically is if there is active degenerative joint disease or not. Okay. And a cone beam CT is better for that than an MRI simply because of, the voxel size, the resolution, spatial resolution, and all that stuff that goes along with cone beam CT versus MRI. Okay.
Well, the second part of that question, Dania, was that this radiologist, who I really admire, gives brilliant reports. And unfortunately, when I've had some patients come my way and they have an MRI report, and I've read it and I thought, hang on a minute, this is really not matching my clinical diagnosis at all. Okay. And that's not my ego saying, hang on a minute, I'm right here. There's few times I really doubted it because it was such a strange one for me. And then I sent the actual images to this radiologist, and the report I got back was completely different, and the quality was obviously much better, much thorough. And this is him being a brilliant radiologist. So I started to then do this a few times, and I've been amazed at the level of, this is the UK, I don't know how it is in any other country, but I've been amazed at the quality of reporting. And so there's image quality that comes into it and having the right equipment and stuff, which I know we don't want to go into, but there's different MRI equipment, different centers, whatnot, and the quality of that varies as it naturally would. But also the interpretation of it will depend on your training. So have you experienced this as well?
The majority of the MRI reports that I write are rewrites.
Wow.
Because
There we are.
let me just give you like how things work in the US. Okay, so when you acquire an MRI, in order for insurance to reimburse it, that MRI is the technical component. There has to be a professional component. And the professional component is the report. So whoever gets the MRI, like in the pile, of course, now it's not a pile anymore, it's the list. Whoever gets it and reads it gets paid for it. Okay. Now, if you're lucky, a head and neck radiologist is going to read it for you. If you're not lucky, it's going to be a general radiologist. Okay.
Yep.
My husband's a radiologist, a medical radiologist. He's a cardiac radiologist. Okay. He says like in his entire residency, he maybe got 1 or 2 TMJ cases to read. Okay. So unless you really care about this area and you really focus on it, then you're not going to really understand it. And even amongst the head and neck and neuroradiologists, they don't get it like we do, like dentists do. Okay. They don't understand what all the stuff that I just explained to you, the occlusion and the facial growth and whatever. I mean, I speak at the American Head and Neck Radiology meetings and whatnot. And they, prior to my talks, they were talking about this morphologically. Where's the disc in relationship to the fossa? But the basic understanding of what all that means, is kind of lost in the medical world. Now, I'm saying there are a lot of good head and neck radiologists who dedicate their lives to learning the TMJ. In fact, one of the pioneers in TMJ imaging was a renal guy. He was not,
wow.
He just had his name is escaping me right now, but God rest his soul, he passed away recently. Yeah, so he was, if you go back and look at the literature back in the 90s, his name was all over the place. He was a medical radiologist who had a genitourinary radiology kind of practice, but he had an interest in the TMJ. His name will come to me, I know, after we talk. We stop talking here. Right, so if you don't dedicate the time to learn this, you're not going to be able to really interpret it. And unfortunately, a lot of the education in the medical world, also the people who are teaching at TMJ, don't understand it like we understand it. So they teach it, they propagate that same information or misinformation. Okay. And I'm not saying I'm right, you're wrong, whatever. Everybody has their opinion. But, I've pretty much spent the past 20 plus years, trying to understand this thing and also understanding it from a perspective of a dentist, because I am a dentist and I serve dentists, right? So in when it comes to the choice of who to choose to read the scans for you, if you have an oral and maxillofacial radiologist, you're golden. If you have a head and neck radiologist, you're close to that. Depends on his understanding and how much he's willing to invest in learn, he or she, of course, learning more. And I think a big part of it is your communication with them. Okay, and that's the missing link right there. Is dentists educating medical people on what they want and what they care about and what all this means to them and what they want to see in their reports. Okay, so
I'm glad you said that. Really validates my experience in a way, because the first time I had this thought some years ago and I felt alone. I was like, am I being silly? And then to ask the patient to pay the fee for the new report. So you know what I did? I paid it out of my own pocket, because I was genuinely curious. And then that validated it. And then in the future, when I then got patients to get re-reported, it's amazing. And so that really taught me a lot. It taught me a lot. And so I gained a newfound respect for your field more than ever before. So it's amazing what you do. And I love everything you said today in terms of really bringing the patient into it. I think that is the beauty and the crux of it, rather than just these images. Is that storyteller analogy going back to the beginning. Any final points that you want to leave to a general dentist listening right now when they're thinking about imaging for their TMD patients before we close off?
Listen to your patients. Take the time to listen to them. Okay, a big part of the TMJ disorder spectrum that they have is going to come from things that are going on inside their heads. Okay, I believe in the psychosocial model as well as believe in the biomechanical model. Maybe I'm a little bit, I'm on the fence which is which, and I think that there are many little, there's a lot of stuff going on here. You can't just say everything is psychosocial. You can't say everything is biomechanical. You got to talk to both fields and both, educate
Camps.
yourself in both camps. Yeah. And then come up with what you feel is best for your patients. And every patient is going to be different. You can't treat people, with a cookie cutter kind of approach, a cookbook kind of approach. It's not like that. The most important thing is to listen, okay, and observe and put your ego aside, okay? And when you're evaluating a patient, the last thing you want to look at is the chief complaint.
Mm-hmm.
Chief complaint or the area of your interest, okay?
Mm-hmm.
So look at everything else and then look at the chief complaint or the area of interest of that for you, okay? If you're an orthodontist or an implant, whatever, that's the last thing that you look at, okay? Because if you don't do that, then you're going to fall into the satisfaction of search error. Satisfaction of search error is when you come up with the answer to the question that's burning inside of you or burning inside the patient, your brain checks out. And you don't approach the patient as pragmatically as you would have if you were to look at everything else first and then the chief complaint. Or
it's really about being more comprehensive. And I think that really describes you well.
Systematic and non-biased.
Not so easy, is we have to really work on that as clinicians. That's not so easy to do.
It's the ego.
It's the ego. There we are. You're so right. Dania, you've done a really wonderful job on a tough topic. So thank you from all of us at Protrusive for doing such a harmonious job, and the way you explain and the whole thing about recapture. I think the penny really dropped for so many of our colleagues today. Can you tell us about your topic in Chicago AES 2026? I'm so glad to kick off the AES Takeover series with you, but tell us about your talk.
Well, it's going to be called Telling the Story of Your Patient Through Imaging.
Perfect.
And it's basically understanding the whole system and looking at the patterns that are predictable and some not predictable, but looking at that through imaging. I mean, really, CBCT has opened up a whole world of diagnosis for us, and for us to poo-poo it or to try to minimize its importance in our diagnoses. We're no longer in the 1950s or the 1980s. We're in a new era where the diagnoses are evolving and our ability to diagnose is evolving, and we shouldn't be afraid to use the correct diagnostic method for the patient who is presenting to us at that single moment at this time, right? So that's basically what I'm going to be talking about, using the imaging to look for the stories in the bones, to look for the patterns in the bones, and how all the moving parts come together and work together.
Well, you're really part of a star-studded lineup, and so we're very excited to learn more from you in Chicago. So hopefully many colleagues will join us for that. You also said you do a fair bit of teaching. Is there anything that you help with dentists? How can we learn more from you? How can we connect with you?
Yeah, I do give every other month. I give a How to Read a Cone Beam CT course online, so virtual. You can zoom in from wherever. And it's run by Concord Seminars. Okay, so Concord Seminars, if you look them up, you'll find it there.
I'll add the link in the show notes for everyone.
Right, fabulous. Yeah, and I just do it for the dentoalveolar part because in order to do the whole thing, I did have a longer course, but it was just too much to sit for 4 days. So it's a 2-day, half-day kind of situation. So 5 hours, and it's a time that works for pretty much every time zone. Not too late at night, not too early in the morning, something in between. I mean, people in Australia struggle, but
Aussies always struggle. Always struggle. God bless them.
Right, yeah. Yeah, and I do have a book. I mean, I don't know if you know anything about it or not.
Yes. I've seen it.
It's called
I'll be getting my
Specialty
copy
Imaging.
signed from you in Copenhagen, so I look forward to that. Well, fingers crossed that all goes ahead. And of course, again in Chicago. So thank you so much, Dania, for giving up your time here to talk about something that you do so wonderfully. When Bobby Supple was discussing with me about all the different guests he had planned and stuff, and he told me a bit more about you, and he told me that you recently, I don't know where you were teaching, was it Milan or something? I don't know, and you got a standing ovation. I forget where it was that he mentioned. And so I can see why. I honestly, having this first experience of chatting to you, I can see why you are so respected. And so keep fighting good fight. We're absolutely loving it. Please keep it up.
Thank you very much. It was such a pleasure talking to you. And everybody have a wonderful day wherever you are in the world.
Well, there we have it, guys. Thank you so much for listening all the way to the end. If you managed to listen, why not claim your CE credit? All paying subscribers to Protrusive can answer the questions. Make sure you get 80% and we will issue your CPD certificate. We are a PACE approved provider. About 96% of our previous episodes are eligible for CE, and we've also got a whole bunch of masterclasses and clinical videos that are also eligible for CPD. So if you're a returning listener or watcher to Protrusive, it's well worth checking out our Protrusive Guidance Network, home of the nicest and geekiest dentists in the world. Head over to protrusive.app and we'd love to see you on there. Thank you so much again to our wonderful guest, Dr. Dania Tamimi. More to come as part of the AES Takeover. Really excited to share with you the episode with Dr. Jeff Rouse coming very soon. And don't forget to head over to aes-tmj.org to see if you can escalate this, to the next step. Can you now ask your spouse for permission to come to Chicago in February to learn more about comprehensive dentistry? I gave you a teaser of day 1. I'll give you a teaser of day 2 in the next AES Takeover episode. Can't wait to see you there if you're coming. Let me know if you're coming. DM me on Instagram or DM me on Protrusive Guidance. Thanks again, my friends. I'll catch you same time, same place next week. Bye for now.